But we're going to move to questions now. And the first question, which I have, is quite a short one, but so I'm going to expand it a little, if I may. And this is from an anonymous attendee who asks, is it true that people in India have huge phone coverage? And I think what this relates to is the role of digital. Now, digital, as we know, has had a huge amount of interest in delivering mental health services in the past few years, especially with the pandemic. But I wonder what the panel think about how digital technology might facilitate people's involvement in careers in mental health research and maybe break down some of the barriers that we've been talking about. I wonder who'd like to speak to that. Perhaps Manvi, would you like to start on that question?
It does actually have a very wide coverage of, where I think even the smallest kids that we see, they have a phone in their hands. And of course, we have a very huge youth population. I think it's somewhere around 25 to 30% population in India is youngsters, is below the age of 32. So we do have a very wide population of youth, and that obviously translates that there's going to be a lot of usage and harnessing the power of digital, as I said. So we do have that, and besides that, I think, but there we cannot be ignorant of the fact that there are obviously with digital come a lot of barriers and challenges. And one of those is that with digital, we're not sure that a lot of people are not aware that a lot of things that are available on the internet may not be from a trusted source, and so you never know what you're trusting on the internet. The second one is that obviously digital, when we're looking at the general population, when I see around myself, I think all of us here are somehow privileged in some sense to be sitting here and be using a laptop and attending this. But there's a lot of dusty corners that we often ignore. And so digital is not accessible to a lot of people. A lot of people have never held a phone in their hands. So that's obviously a point. But I think for a moment, when we see the positive side is that there is in fact a lot of improvement, and a lot of people are increasingly becoming aware of digital. And in fact, the fact that this webinar in itself is a whole digital science festival itself translates to how digital has become so important, especially in the field of mental health, where such webinars, online therapy sessions, advocacy, activism, and a lot of things have moved online. So I think, digital has played a powerful role in the past couple of years and will continue to play a powerful role in the years to come.
So Nev, I wonder what you make of that. I mean, clearly there's the potential for great inclusion, but the other thing I got from what you said, Manvi, was that there's the potential to in some ways widen the degree of exclusion for people who don't have access to digital.
I think that's a big concern, and also at a more kind of macro policy level, the risk that technology becomes a substitute for really investing in training and quality improvement within the mental health workforce. And I think that's a lot of what we're seeing in the US is literally the development of avatars to replace, whether it's peer specialists or kind of peer supporters, clinicians, psychiatrists even, based on very kind of complex algorithms. So interacting with an individual who is not human, who is AI. So I think there's a real risk also there of diverting funding away from actually exactly what we're talking about, which is investing in the not just the research, but the workforce in the broadest sense, providers, practitioners, and diverting that money into kind of tech development. And there's risks of privatization there. And then privatization, especially in a global context, we see again and again play out in a way that ultimately exacerbates global north-south inequalities, because who holds the patents and who controls the technology.
Yeah, so that's a good point, Nev, which is that this stuff hasn't sort of arrived in our laps, that someone owns it and someone controls it, and we need to think about these concerns when we're involving technology in all parts of mental health, including service delivery and, of course, in career development. Ruby, I wonder if I could turn to you, if you could pop your screen on, please. Okay, I think Ruby's having some problems joining us, so I'll turn to to Ollie. I wonder if you could respond to those points about the potential for digital's involvement in developing mental health careers and what some of the downsides might be.
So I guess for me, initially, I think one of the upsides of digital can be on helping to drive that collaboration across borders and across boundaries, because I think often as mental health researchers, we can get quite siloed, and particularly if we're working in smaller institutions or places that don't have a great deal of experience within mental health research, being able to communicate with people from all over the world and from other institutions, from other countries, cultures, I think is really powerful. So I think that there are some really significant benefits, and I think that some of the potential downsides highlighted by Manvi and Nev, I think are really important to kind of bear in mind in terms of making sure that we don't prioritize necessarily some of the digital stuff at the expense of individuals and, you know, having humans involved in the research. So I don't really have anything else to add to that.
So Kathy, your project is specifically a digital project, and that's something which would maybe not have been possible, 25, 30 years ago. Do you think that there's some transformative potential for digital in increasing the visibility of diversity within the mental health field and providing the opportunities for people to link in and be encouraged to join?
I mean, I think there definitely are. I think I'd very much reiterate what others have said, that, you know, there are huge opportunities from digital, but with that comes some risks that we need to be really careful about. I think we've definitely seen over the last couple of years the move to more working online and sharing through digital has definitely, I think, helped inclusivity in mental health research in many ways, particularly in a lot of the work that we do with, so I work with children and young people with mental health problems, and we work a lot with parents and carers as well. We've been able to involve people with lived experience with much more, a more diverse sort of range of backgrounds and experiences, because we've been able to engage people online as well as face to face, which is just much more accessible for many people, particularly, if people have caring commitments, people live in rural locations, if people have mobility issues. I mean, there are all, lots and lots of reasons. And I think that applies to the researchers themselves as well, of course. And through the GROW programme, certainly the fact that a lot of it has been done online has worked very well for many researchers who would have found it very difficult to come together physically on every occasion. But having said that, it's also been really notable how important the face-to-face events have been as part of that programme, and how people have definitely felt they've got something extra from those. So it's all about trying to get that balance of making use of the opportunities digital brings, but not forgetting the importance of those in-person interactions, as others have said.
Thank you. So we have a lot of questions and not a lot of time, so I'm going to move on to the next one. This is a comment from an attendee from Nigeria who says, I think one challenge to developing a career in mental health is veiled or even open family and societal resistance towards those at the verge of considering careers in mental health, especially in a low middle income country like mine, where stigma is still an issue. So is this a barrier, do you think, to people getting involved in mental health research? Manvi, what do you think?
It's definitely a barrier. In fact, I think stigma kind of, I see it as an anti-democratic element that exists in the mental health space, because it does not allow those with lived experience. I mean, the basic concept of democracy is to basically hold everybody together and make them the base of all the decisions that are being taken place, and make them the base of all the programs and policies that are taking place. However, what stigma does, it in context of people with lived experience, it does not allow them to come in the picture. It makes it an unsafe space for them to come in the picture. And then that itself, I think it de-democratizes the entire space of mental health and its development and mental health research. So I think, I definitely see it as a huge challenge.
And of course, this is highlighting the challenge in low and middle income countries, but I think it's also maybe still a challenge in some high income countries. And I mean, Ollie, I wonder if when you chose psychiatry as your specialty, what the attitude was of your peers towards that, and to people at your medical school, your training scheme.
Yeah, I think it's really interesting because that stigma definitely exists within the UK as well. So I had a lot of questions from family to start with, saying, you know, why would you want to work in mental health? What is it about mental health that's attracting you? And it wasn't necessarily it was very veiled stigma. So the intention behind it was clearly, please don't do that. But it was said in a way of kind of questioning me. And then peers as well. So I have had colleagues throughout my career who've said things like, oh, why, you're a good doctor, why are you wasting yourself on a career in mental health? You could be a renal physician or do intensive care, you could be a surgeon. And I would always just say, I'm not interested in those things. There are other doctors who are. My passion is working with people with mental illness and trying to make a difference to those people's lives and trying to help some of the people who I think are the most vulnerable in our society. So that stigma, I think, definitely exists. And I think maybe in the UK and in other kind of more economically developed countries, it's maybe slightly more veiled than it is in other areas of the world, particularly the global south. I think the other thing that I would say is that in our work, or in my work, I often come up against a lot of stigma from people who, or not from people, but within families. So for the patients, or the service users who have mental health problems, and sometimes that stops people getting involved in research as participants. And I've had it before where, I've seen somebody in the clinic and said, come to the conclusion that this person maybe has a diagnosis of a mental health condition, and said, there are research opportunities if you'd like to be involved in studies or, questionnaires, whatever it happens to be. And families kind of just saying, well, no, absolutely not. This is for the family. This is just for us. So I think anything that we can do to try and break down those barriers and break down that stigma is absolutely essential. And I think that a lot of the work that organizations like MQ do is really helping to challenge that, and the amazing work of my co-panelists, really.
So Manvi, you've got your hand up.
I started to publish my story as an opinion piece at a lot of places when I first wanted to tell everybody that, okay, I live with this condition, I'm not ashamed of it. So when I did that, I think the first stroke of stigma that I received was from my own family. Because they started to feel that, you don't have to, why do you have to necessarily put it out there? Why do you have to let people know it's a personal thing? And they tried to cover it up using all other kinds of excuses, but it was stigma, which was, it was stigma disguised as other excuses. So I think that's definitely relatable. There is still stigma, especially, I think stigma is a little lesser in high income countries and a little more in low and middle income countries. Also, I think when we speak about problems like stigma, we often do not take into consideration stigma in rural settings, because especially in a country like India, like I have seen it around myself, stigma in rural settings is on a whole new level. It's termed as somebody being possessed. And a lot of those things. So I think that at times, it's very painful to see all of that happen. And that is also something that organizations today want to tackle, but are not able to. They're not able to find the right resources or the right approach on how to tackle stigma in rural settings. So I think, I just wanted to address that and add it on so that we also have that in our minds.
You raise a very interesting point there, Manvi, which is that I think one of the things over the past few years we've come to recognize is the importance of communities. And I wonder if the community of lived experience and the community of mental health research might of itself help to counteract some of that exclusion and that stigma, or at least that in theory it might. I wonder, would you think of that, Neb?
Sorry, I was just typing.
That's
Say that
right.
one more time now.
That's right. Manfred's just been talking about stigma, and that it's very widespread, that exists within professions, exists within families. And I wonder if the kinds of communities which can be offered by lived experience involvement in mental health research might help to counteract that in some way, if there's maybe a supportive role there.
Yeah, I mean, realistically, we want massive cultural change. Um, while we are all sort of chipping away at that, I think absolutely. And what I was just typing actually in response to Catherine was about some of the specifically sort of lived experience research networks that exist, but also, there's equivalents obviously for advocacy, activism, policy roles. And what I think is partly so powerful there is that when you're experiencing kind of stigma in isolation, it's very powerful. And when you have other people who are also experiencing that, to kind of discuss and just get that sort of validation, and validation in the sense that you really know that they know exactly what it's like, they exactly kind of understand and grasp what you're going through, that really helps to kind of deflect a lot of the sort of the negative power of those experiences. And also, I mean, it's ultimately it's collective kind of organizing, collective initiatives and efforts that are going to bring about change. So the more that we can get people together, there's much more power in us when we come together as groups than any of us have as individuals. So yeah, I think those things can play a powerful role. And we also see it, graduate students suffer a lot, right? All different forms of sort of labor exploitation, extreme stress, extreme sort of competition for far too few jobs and positions. And so I think, again, you actually see a huge amount of kind of mutual aid and mutual support just happening among regular psychiatry trainees and graduate students, like in general. And that's hugely powerful.
Thank you. That's interesting. And I wonder, Kathy, we've heard so much more about mental health in the mainstream media in the last 10 years, especially. I mean, that's certainly a change I've noticed since when I joined the Lancet in 2010. There's very little about mental health in the media. Now you'll read a story about mental health practically every day. Is this, from your point of view, having a destigmatizing effect with people going into careers in mental health research? Have you seen this reflected at all in your work with the incubator?
Yeah, I think it's very hard to say whether that's had an impact on numbers of people wanting to go into mental health research careers, because we know obviously our capacity, the size of the workforce is still very small relative to many other research areas, and definitely we're punching well below our weight. So it's hard to know whether the size of the workforce has increased as a result of that. And I guess there would be quite a slow trickle through anyway, quite possibly. But I know certainly, as Ollie was saying, I mean, in psychiatry, there's a huge lack of people moving into research. And I think, and what we would hope is that, younger people who've grown up, certainly, I think this is true in the UK, with a much more open dialogue about mental health, I hope will be much more open and interested in taking this stuff forward. So as we move forwards, we'll be able to see those differences, but I'm not sure we've seen the knock-on effects as yet. But I guess that even, there's two parts of it, isn't there? There's one is that we need people to see mental health research as an important and valued and valuable thing to do. The other is we have to make sure the opportunities are there for them to be able to pursue it. And I know that I can see in the comments, that's often one of the challenges that people face as well.
Thank you. And Nev, go ahead.
Well, I just wanted to also make the point, Niall often makes this point, but there's hierarchies even within mental health. And I think experiences and conditions we label as serious mental illness, like schizophrenia, often are really stigmatized even within the larger mental health fields. And in the US, we have an absolutely astronomical program around, at all levels, social work, counseling, psychology. Psychiatry, I think it's less of an issue, interestingly, right? But for the sort of psychosocial side disciplines, folks not wanting to work with individuals experiencing schizophrenia or other, again, what we would label as serious mental illness. So I think that's something to say too, and that where even in countries where we see some progress on stigma against depression and anxiety, we actually well documented, really solid epi research showing worsening of stigma towards people with, for example, schizophrenia. So I think we have to keep talking about that.
We have a few more questions in the chat now. The first is thoughts on what opportunities for people with lived experience are missing from mental health research and what could be done to open these opportunities up. Now, this, of course, we've spoken about, but if anyone has anything to add on what those gaps are of opportunity and how they can be addressed, I'd be very interested to hear it. Manvi, I wonder if you have any thoughts on this.
I think there's a couple of things that that one could definitely add there, and that is that when we're speaking about lived experience, I think we also need to consider that with lived experience of mental health conditions or mental distress, there also comes lived experience of a lot of other, intersectional factors. Like somebody could identify as being a part of the LGBTQ community, and they could be living with a mental health condition or mental distress. So when we're speaking about opportunities for them, how do we uniquely design those opportunities, and what are the unique needs or requirements that we'll need to design for those specific opportunities? So I think that is definitely important, and that is also missing when we speak about opportunities for people with lived experience. We often miss out on the intersectionality part of those opportunities. So yeah, I think that's definitely important. Another thing is that we talk about engagement, but I think it's also very important, like I said, as part of my presentation as well, that we also speak about leadership by people with lived experience, because we do not just want to be involved, at a stage where there's already a blueprint in front of us and we're asked that, what else do we add to this blueprint or what do we subtract from here? But it's also very important to have those with lived experience from a stage where you just have a blank paper in front of you and you ask them that where do we and how do we draw the first line on this paper? So I think it's very important to have, those with lived experience. There's a gap. Like, I think they're being involved and engaged, but they're not leading yet. We have very few leadership positions for those with lived experience, and I think that is something that we need to definitely work on.
Thank you. Ollie.
I think one of the big challenges is often funding. So particularly in my experience, applications for funding almost always center around a researcher-focused approach. And actually, the NIHR, which is a UK-based organisation for health and care research, recently had a funding call out, which was trying to drive more people with lived experience to be more deeply involved in research design. And often the funding calls that come out from funders ask for, did you have any patient or service user or carer involvement in the preparation of the bid? And it almost feels like an afterthought sometimes. And I think that if there were more programs that more deeply embedded that into the research focus, I think it would be really powerful. So I think that would be one way of improving and increasing the lived experience voice, really.
Thanks. What I'd like to do now is open this question out by adding another to it. Now, we've got a couple of questions in the chat. There's one specific one, Kathy, which is a yes or no answer, which is mental health research incubator offered to non-UK citizens?
Sadly, no. So I did put a slightly longer response to that in the thing, but because it's funded by the Department of Health and Social Care, currently not. However, we've learned a lot from doing it, and it would, I think, require a different funder to be more widely available. However, we've learned a lot from doing it. We'd be very keen to share that if there are other opportunities for people from other parts of the world.
Thank you. Now, the next question which I have is again quite a specific one, but I think we can broaden it out to some of these themes we've been talking about. Now, this person has asked what short courses or programs are available for those whose basic or first degrees are not primarily in mental health, but want to get additional knowledge or certifications in mental health. Now, if you know of any of those, please put them in the chat, or I'd like to hear about them. But I think this also speaks to the point you made, Nev, about this fact that we say we want this diverse field, we say we want everyone's voices to be heard, and yet we have these, as you put it, cookie cutter ideas about, high school degree or, sixth form degree or whatever, followed by a university degree, postgraduate, list of publications, lists of projects funded, and the decisions are still made on that basis as to who gets to speak, who gets published. How do we begin to break out of that, Nev?
Oh, that's another. I mean, I think there's very entrenched cultural, and I mean culture in academia, academic culture, research culture, and because it's such a long training process, by the time you get to be certainly in any, even a lower level leadership position in academia and research, you've been through years and years in the system, being acculturated to thinking and valuing certain things. It's a hugely bureaucratic. Universities are, as sort of types of entities or institutions. And so it's very hard to change things. So I think one sort of low-hanging fruit that helps is if more conferences and events really reoriented themselves to deep discussion and critique of these issues. So I think the sort of the invisibility people have on their own one-off conversations all the time, I'm sure, but in invisibility when it comes to more kind of public forums and conferences and deliberations. So I think that that's something that would really help. MQ, welcome, well-positioned sort of funders and foundations could really kind of help push some of that, and push when it comes to funding, a different metrics being deployed to really look much more deeply about level of involvement, level of compensation, and like really trying to guard against the sort of much more kind of tokenistic or kind of hierarchically subjugated ways in which the diversity in various ways, right? This also happens on race, ethnicity, geography, right? Global South inclusion. So often we see it's really tokenistic. So, I mean, I think we have to be we know that is what we're going to expect. The norm is going to be tokenism. How do we push groups, centers, proposal teams to move away from that?
Yes, and I think one of the things in mental health is that we hear a lot of time, perhaps appropriately so, the language of crisis and the language of urgency. But of course, one of the problems, if you're always in this mode of crisis and urgency, is that's inimical to diversifying in some ways, because when you feel that you're in an urgent crisis situation, you'll tend to reach for what you know and for the people you know and for things you're comfortable with. So maybe what we need to do, as well as build those spaces where we can sit back and do those sort of deep dives and those conversations. Kathy, I wonder what you think about that.
Yeah, well, just picking up on the point you're making there, I think that we have recently through the UKRI mental health research networks, we've seen some really good examples of how that's been addressed, because so UKRI supported 8 mental health research networks, and which were really about building communities and facilitating kind of underpinning research to grow capacity. And what that meant, and it was very much a focus on throughout them, meaningful involvement of people with lived experience and work across disciplines and across sectors, and that's been very true of all of those networks. And it meant, for example, when the pandemic came along and there was an urgency to deliver research, it meant that some of the networks were really well equipped because they already had really good working relationships with people with relevant lived experience, had really good cross-sector networks, et cetera, and I think that has really shown in how the networks were able to respond to the pandemic. And one of the things particularly that's been done across the networks, we certainly did this in Emerging Minds, which is the network that I lead, is supporting the development of special interest research groups. And the way that we did that in Emerging Minds is that we received applications for special interest research groups to address areas of unmet need in research, and we provided funding specifically to support lived experience involvement. And so what that meant was that these groups could get together, have discussions, have conversations, think about where they wanted to take the research, prepare grant applications, put together workshops and so on. And the lived experience part of it was funded, and which, as Parissa's mentioned in the chat, is often a real problem. So not only did it mean that those people were poised if a grant call came out, but also they just had a bit more time to be able to think with people with relevant lived experience about how to take the research forward. So I'd really encourage the funders on this call to be sort of thinking about those kind of models and how they could be used going forwards to enable, you know, meaningful lived experience involvement rather than this kind of rush that we often see.
Those who have seen me chair panels before know that I like to end with a roundup question. And my brief for this is that I like the question to be answered within the length of time of a very short elevator journey, or 280 characters or less. So my question for all of our panelists in turn is, what one line would you say to encourage someone into a career in mental health research? Manvi, I wonder if we could start with you.
That's a tough one. That's one I didn't prepare for. All right. I think the one line would probably be, you know, like, I'm a lived experience expert, so keeping that in mind, I think the one line would simply be that speak your truth. I think it's not even a line, it's just 3 words. I think that is, and I think anybody with lived experience, you know, or anybody who has actually been through anything, I'm sure we all have been through our own battles, would understand what that means without me having to actually elaborate much on that. So I think those 3 words can do really magic.
Thank you. Nev.
Mine would be the change you want to see.
Fantastic. Thank you. Ollie.
I think I would say to healthcare professionals who want to be involved in research, clinical careers are fascinating and amazing. You can make a difference to individuals' lives, but by doing research, you can make a difference to potentially hundreds or thousands or millions of people's lives. And if that sounds interesting to you, then come and join a career in mental health research.
Thank you. And finally, Kathy.
I was going to say a very similar thing to Ollie. You know, there's still so much that we don't know. There is so much that we need to know. So there is a huge potential to make a huge difference by getting involved in mental health research.
Thank you very much. Thank you for such a fantastic discussion. We're now going to move on to the next point in our proceedings. But before we leave, thank you again to all of our panel. Thanks for all the fantastic comments in the chat. And I look forward to the rest of the afternoon.